This week we're going to talk about delivery methods. One of the most common O2 delivery type devices for long-term care is the nasal cannula. Advantages of the nasal cannula: it's a low flow device. In most cases, in the home setting and even the alternative sites, because they don't have piped in oxygen most of the time, you may find concentrators. Most of the patients that are on O2 therapy is usually on some type of low flow cannula. It can range anywhere from 1 to about 5 liters. Other methods, but not quite as common, of delivery devices is the simple mask, air entrainment type mask like the Venturi mask. To decrease O2 usage and costs, they've developed many types of O2 conserving devices, and we're going to talk more about that in this PowerPoint. Then also there are transtracheal O2 catheters, reservoir type cannulas, and also the demand or pulse dose O2 delivery systems. In this week I also have a video on transtracheal O2 catheter as well as the pulse dose type system, so you get a chance to see what the difference is between a continuous flow O2 therapy as well as the pulse dose O2 therapy. So as a rule of thumb, when we're looking at O2 conserving type devices, it can inhibit performance compared to the nasal cannula at approximately 1/3 to 1/2 the flow. So based on this type of information, when you're switching a patient from a 2-liter nasal cannula to an O2 type of conserving device, as a rule of thumb, the RT will start off at about half of the original flow. For example, you will start off, if someone was on 2 liters, try them at 1 liter, and then you're going to assess with a pulse ox whether or not you need to adjust the flow up from there to assess tolerance. And as I was saying before, I have a video on this type of delivery method I'm going to talk about next. This is the transtracheal O2 therapy. It's abbreviated TTOT. And what it is a delivered O2 delivery type device that gives oxygen via a catheter with a very small orifice. And that orifice is inserted through the skin right at the neck tracheal area, in the neck tissue to the trachea. And there's a diaphragm there we can kind of see on the side, the tracheal cartilage, the insertion site where the catheter will go. And it goes right between the 3rd and 4th tracheal cartilages. So the transtracheal O2 therapy is not quite as common as the other type of devices. One thing that's nice about it, if someone does not want to have a O2 cannula on their face, they can opt for the transtracheal O2 therapy. However, it is an invasive type of device because it has to be inserted through the skin, but it can be covered up very easily with clothing. You can put a scarf around your neck, or for a man to button up his collar, you would not be able to see that the device is there. And usually because you're going right into the trachea, it does not require as much O2, so your O2 level of liters in flow is a lot lower, and it achieves the same therapeutic effect as if you were having a cannula in your nose. In order for a patient to be able to benefit from the transtracheal O2 therapy, there are several indications that you will have to look at. Only for patients who meet one or more of the following criteria can they have this type of O2 therapy device. It cannot be adequately oxygenated with standard approaches. Do not comply well when using other devices. Exhibit complications with the nasal cannula. If they have a lot of nasal irritation, maybe their septum is kind of deviated, or they have major problems with it, they might be a better candidate for the transtracheal O2. They prefer the transtracheal O2 because cosmetically they don't want to go around with a nasal cannula in their nose, so everybody can see that they're impaired of some sort. So like I was saying before, with the transtracheal O2, you can kind of cover it up, put a scarf around your neck, wear a turtleneck, or you can, for the guys, they can button up their shirt and no one even knows that you have it. Also, having a transtracheal O2, it makes it easier for mobility. So you don't need as much oxygen. You can have just a little small purse-like oxygen concentrator or some sort similar to that liquid oxygen, and you can get around a lot easier without any decreases in mobility. Another reason to use the transtracheal O2 therapy, you may be someone who's had trouble with sleep apnea. So this may be a treatment alternative for patients with sleep apnea when CPAP is not tolerated. Some patients don't tolerate having that mask on their face. They're claustrophobic, or maybe they just feel like they just can't have something on their face when they sleep. They just can't do it. Or when combined, O2 and nasal CPAP are required. So if you have someone with a little bit of higher oxygen needs and they're trying to put a cannula on and a nasal CPAP and they're still having a hard time maintaining their levels, being that the transtracheal oxygen goes directly into the trachea, it may be a better alternative for the patient versus having to use a lot of other devices. So for this type of TTOT type therapy, success when using it is based off the patient's effective patient education. So they have to know exactly how to use it, how to care for it, when they're in trouble, when they need to seek help. So they have to be pretty self-sufficient and independent to be able to have the TTOT. Ongoing self-care, and they have to make sure that they follow up with their lung specialists just in case there's any issues, to make sure everything's going well and they don't need a titration in their oxygen liter flow. In this box, 51-3, it has the guidelines that are told to the patient with the transtracheal oxygen catheters. One thing I do want to point out, and there's a lot of information on here that you can kind of read on your own, but I just want to point out here that if the equipment becomes split or broken or develops a permanent kink or foul odor, immediately discard and replace. Catheters and hoses should be routinely replaced every 3 months. So I would imagine that the switch out is similar to a trach switch out. It should be fairly easy. The patient will be educated on how to do this, or the medical professional in the doctor's office will switch it out for them. But it sounds like this should be something that's fairly easy for the patient to do as well. So they have to always kind of watch their insertion site, make sure there's no redness or infection, pus. If their catheter is split, they need to replace it. And they always have to kind of keep it clean and sterilized with like vinegar water and things like that. So just a few things to kind of think about for the patient who takes care of themselves with the transtracheal oxygen catheter. The next delivery method I'm going to talk about is the demand flow O2 system. An example of that will be the pulse dose O2 conserving device. It uses a flow sensor and valve to synchronize gas delivery with the beginning of inspiration. So as they breathe in, kind of similar to when a patient is on the ventilator with assist control, the vent senses that they want a breath and then it gives it to them. Same thing with the pulse dose. When the sensor detects the person's breathing in, then it gives them the oxygen. Therefore, by doing it that way, there's no wasted oxygen like it is with the continuous O2 nasal cannula. So you can see from the diagram, the top one, which is A, is the continuous flow oxygen. And there's a little waveform to kind of tell you the dead space and inspiration versus exhalation. And then B deals with the pulse dose oxygen. And you can see there's not as much waste. You can see also their inspiration as versus the expiration. So the demand oxygen delivery device, most of the oxygen is delivered with the continuous one on the first half of inhalation, with the remainder wasted. With a coordination of the pulse, most of the oxygen is delivered during the first 25% of inspiration. And as you can see from the diagram, there's no waste occurring with that type of method. So with the demand flow O2 system, the pulsed O2 system can produce an SaO2 level equal to the levels that are seen with a continuous flow using, of course, 60% or less O2. The pulse dose cannot be used for someone who has high oxygen needs. So if they have minimal oxygen needs, 2 or 3 liters, maybe even a little less, they will be perfect for the demand flow O2 system. Because it's not giving oxygen continuously to dry out the nostrils, it's only when the person needs it. Usually there's no need for humidification. So having successfully been adapted for usage also with the transtracheal catheter for more efficient O2 delivery. So it also, in more recent studies with the science, can be used in that fashion as well. So Medicare reimbursement guidelines provide no significant additional payments to cover the additional costs for demand flow system. Like I was saying before, the demand flow is good for patients who do not have a high oxygen need. However, if the patient was to exert themselves during exercise, etc., they may actually desaturate with the demand flow because it's not giving continuous, and you tend to inhale a lot deeper and have more of a need for more flow when you exercise. So if you have a patient that is lung compromised, that can probably be a problem compared to someone who does not have lung disease. However, recent improvements have made them more reliable and user-friendly. Technology has improved over time. It was not quite widely accepted or even known about several years ago, but technology is changing. They're improving it as far as how it can be used, and as a result, increases in the duration of flow by 2 to 3 times have made it more accepted throughout the community as far as medically with the doctors and patients. So they've made modifications to make it so you can even get more flow from it if need be. The demand flow O2 systems, even though pulse dose is very nice to use, is more for patients that are living in a home setting, that are ambulatory, going to appointments, grocery shopping, seeing a doctor. They're more active. Consider standard practice for ambulatory patients using compressed or liquid O2 in alternative sites. So you wouldn't typically see pulse dose in an LTEC or a SNF or even subacute. You will see it mostly in pretty much in home care, where the patient is self-sufficient in taking care of themselves and desire to be more mobile. When selecting a long-term O2 delivery system, you want to keep in mind the 3 P's, and the 3 P's consist of purpose, patient, and performance. So the goal is always to match the performance of the equipment to both the objectives of therapy, which is also purpose, and also you want to look at the patient's special needs. So you want to match the performance of the equipment and figure out, okay, what is we're using the therapy for, so what is the appropriate device, and then in special cases, can this person use a concentrator, or they're mobile and self-sufficient enough that maybe the pulse dose will be more suitable. This next section, I'm going to cover problem solving and troubleshooting with the different types of oxygen devices. Most problems occur with the devices is due to human error. So it's always important to make sure that the patient and caregivers fully understand what they're using and how it works. Have them do return demonstration. Give them booklets in case they forget how to do something so they can refer back to it to reference. So majority of the time when there's problems with the equipment is because patient and caregivers often fail to follow proper instruction or comply with the prescribed therapeutic or maintenance regimen. When we're looking at the transtracheal catheters, most of the time with the catheters, it's in relation to the initial catheter insertion or the ongoing maintenance. So in box 51-4, there's a listing of complications of the transtracheal O2 therapy. And most of it has to do with the following list of items there: bleeding, pneumothorax, bronchospasm, sub-Q emphysema, catheter dislodgement or lost track, increased sputum production, blockage by inspiciated mucus, infection or abscess, extensive self-care and cleaning to avoid infection or blockage, and track tenderness. So it's important for these patients with the TTOT to report any problems that they're having to the caregivers or the RT or the physician. So the RT, if you're going into the home and you're doing home care and you're inspecting the catheter, the RT should report any evidence of tract tenderness, fever, excessive cough, increased dyspnea, subcutaneous emphysema to the patient's physician. To avoid complications or product failure, catheters and their tubing, like I had said before, should be replaced every 3 months. And these catheters should be cleaned daily, of course, to prevent infection and other problems. And it's very important that the patient check up by the physician regularly for any other things that they may not even realize is going on. So they need to follow up with their doctor just for ongoing care. When we're looking at the demand flow systems, box 55-5 talks about the potential problems with demand flow oxygen systems. There's a few things listed here, and I'm just going to highlight. The devices can be cumbersome and cosmetically unattractive. Initial maintenance costs of the equipment can be high and not fully reimbursed. Earlier devices may possess poor response times and delays in the valve opening and closing, but hopefully with more recent technology, this has been improved. Devices can tend to be fragile and can damage easily if they are dropped or they fall. Most units require batteries, and it's a kind of a problem to have to keep charging and replacing it. And catheters and sensors may malfunction because of sensor dislodgement or plugging, or changes in the patient's breathing issues. So what is the best O2 delivery system for the following patient? A stable home care patient with restricted activity needing low FiO2. What is the best O2 delivery system for the following patient? An active home care patient with low FiO2 needs who desires increased mobility. So please always keep all these items in mind when you're thinking of what is the type of equipment that your patient should use in the home care setting. It may be the TTOT or it may be the demand flow type of conserving devices. But hopefully all these different type of devices will be able to help the patient have more mobility, freedom, and ease of usage with low flow type of leader flow and conserving oxygen wastage.